Hi everyone. Today we're going to talk about modifiable risk factors for migraine. Now I made this table, it is evidence-based, and there is more to it. So we're going to discuss all the factors. However, if you want the full table available at your disposal, it will be in a link in the description. So modifiable risk factors for migraine often get overlooked, but they are very important. First, we have to define what modifiable risk is. What are modifiable risk factors? What does this mean? So these are conditions or behaviors that increase disease risk, but they can be changed through lifestyle modifications or medical interventions. So, for example, if we consider cardiovascular disease as an example, hypertension would be a modifiable risk factor that can be lowered through diet, exercise, medication. High cholesterol is another one. It could be managed through dietary changes and statins if necessary. A person could quit smoking. Increase physical activity. So there are ways to decrease cardiovascular disease risk. If, for example, we imagine a 55-year-old patient, high blood pressure, quit smoking, begins walking 30 minutes daily, they're lowering their 10-year cardiovascular risk from, let's say, 20% to 10%. So they're cutting the risk in half by 50% just by focusing on these modifiable risk factors. Of course, there are risk factors that aren't modifiable as well. For example, it's a 55-year-old patient. You can't change your age. So the same concept applies to migraine. We can't change genetic predisposition, unfortunately. Change age. We can't change biological sex. Women are more predisposed to migraine. However, there are factors that we can identify and modify that can influence frequency, severity, and progression of migraine disease. Again, the data we're looking at today is very evidence-based, and they're not just associations, but rather causal relationships. So let's begin. Alcohol intake frequency, the first one on the list. This has a clear causal relationship with migraine with an odds ratio of 1.25. What does that mean? This means regular alcohol intake increases migraine risk by 25%. So it's important to note that I'm not talking about triggers here. This is about progression of migraine. In fact, there was a recent meta-analysis on wine that showed that wine is not a trigger for migraine on a population level. It still might be your trigger, but it can't be generalized to the population. So in practical terms, someone who enjoys a daily glass of wine might experience significantly fewer migraine days by reducing to 1 glass weekly, for example. That 1 glass is not a trigger because we are talking about migraine progression. So we also have lifetime smoking index. This carries an odds ratio of 1.24. So if a patient smokes half a pack daily and experiences 8 monthly migraine days, after quitting smoking, they may see migraine decrease to 6 to 7 days per month. And you might be thinking, well, less 1 monthly migraine day a month isn't substantial. But for one, it is to a migraine patient. 1 day is huge. 1 day of freedom from a migraine attack is significant. However, if we are able to try to address multiple factors, it will add up. Physical inactivity, that's another significant risk factor. So what's interesting about physical inactivity is that the relationship is bidirectional, and many migraine patients avoid exercise because they feel that it might trigger migraine attacks. And it may. However, research shows regular moderate aerobic exercise actually reduces attack frequency and severity. And so it's a modifiable risk factor because we are talking about migraine progression, not triggers. So from a physiological perspective, exercise increases endorphin levels. We also have improved sleep quality, reduced stress, which is all beneficial for migraine prevention. So the key is gradual introduction to physical activity. Hydration. You can start with a minimal amount, maybe just 10 minutes of walking time, 3 times weekly, slowly building up. Of course, don't start any exercise plan without referring to your healthcare provider. These are just examples. High caffeine intake. Now, caffeine may help some people with migraine. However, in terms of migraine progression, high caffeine intake has been associated with migraine progression and also withdrawal headaches. Next, we have medication overuse and adaptation. So this is a particularly troubling cycle. We talked about it a lot. It essentially occurs when patients use acute medications frequently. Again, not all GPANs are on that list, for example, and some are more prone to causing medication adaptation than others. So from a neurobiological perspective, the chronic exposure leads to adaptive changes in pain processing pathways. Now, this isn't the fault of the patient. It just means they have frequent migraine attacks and they need to treat those migraine attacks. However, unfortunately, there's a phenomenon where treating these attacks with abortives may contribute to the cycle of migraine progression. And that's exactly what happens. However, it is modifiable in the sense that a neurologist can optimize a patient's preventives, decreasing the necessity of abortive meds that cause medication adaptation headache. And again, maybe also switching to another medication like a GPAN that isn't known to cause medication adaptation headache. So we're done with the lifestyle factors. Now there are sleep patterns. Insomnia, odds ratio of 1.2. However, interestingly, excessive sleep can also be problematic with an odds ratio of 1.6. This shows the importance of sleep hygiene and maintaining regular sleep schedules. So I always emphasize this a lot. I always say schedules are more important for migraine care, not routines. If you don't know what I mean by that, check out my migraine triggers video. And any sleep disturbance as well. So establishing a consistent sleep schedule, even on weekends, which may be hard to do, but often necessary for migraine patients, can reduce attacks by stabilizing circadian rhythms and associated neurotransmitter systems. So next, we're going to go into the dietary factors. So the relationship between diet and migraine is complex. There's a lot of misinformation out there. However, according to a recent Mendelian analysis, higher carbohydrate intake and higher sugar intake specifically increase risk for migraine with aura. Not without aura, but with aura. Irregular meal timing also increases risk. Again, schedules with migraine are incredibly important. Now, this is important to know. Food triggers vary among patients, and there is no consistency, even in studies. However, the patterns of irregular eating, skipping meals, they almost always contribute to migraine in everyone. So this suggests metabolic stability is more important than avoiding specific foods. So I'm going to write this here because it's incredibly important. Metabolic stability is more important than so-called food triggers. Again, schedules are important. Regular meal times. And if there's migraine with aura, maybe consider these modifiable risk factors. Now, hypertension stands out at an odds ratio of 1.76. We're now in medical conditions. So this is actually one of the strongest modifiable risk factors. So let's just put this in perspective. A patient with uncontrolled hypertension has a 76% higher risk of migraine compared to someone that is normotensive, someone with normal blood pressure. So this relationship likely involves vascular endothelial function and inflammatory pathways common to both conditions, hypertension and migraine. Obesity as well, and mood disorders like depression and anxiety. They not only coexist with migraine, but they actively worsen outcomes. We know that adipose tissue, aka fat, provides an inflammatory state for patients. Therefore, this lowers migraine threshold. Let's say that's MT. So obesity will actually lower migraine threshold for migraine attacks, therefore contributing to migraine progression. So for patients with both obesity and migraine, even modest weight loss of 5 to 10% can reduce headache frequency. As far as depression and anxiety, this relationship is often bidirectional, and it involves shared pathophysiology involving serotonergic pathways, inflammatory markers, and the hypothalamic pituitary adrenal axis. So there's a dysfunction in the hypothalamic pituitary adrenal axis. Treating depression is known to improve migraine and vice versa. It also makes the migraine patient more responsive to treatments. And that's why you'll often see in studies that patients may need to be on medications for longer if they have depression to identify if these medications are actually effective for them. Interestingly, you often see the same with obesity, but this is likely for different reasons. So let's scroll down here and we have reproductive factors. Now, this will be about the mother's risk. It's not something that the mother does to the baby. It's about the mother's migraine risk. So reproductive timing influences a woman's migraine risk profile. The later age at first birth actually offers protection against migraine with aura, while early age at first birth increases risk for migraine without aura. And this likely relates to lifetime hormonal exposure patterns, specifically with estrogen. And we know this because estrogen influences cortical excitability, and it influences pain processing. And you might wonder, well, is this really a modifiable risk factor? And you're right, we can't modify past reproductive timing. However, understanding this relationship helps us identify at-risk individuals and implement other preventive strategies. So, can it be a modifiable risk factor? Yes. Is it not going to be a modifiable risk factor for most? Yes. So, nutrient deficiencies. So, there have been multiple nutrient deficiencies that have been linked to migraine pathophysiology. And I just want to say that any disruption in nutritional balances potentially contributes to migraine progression. However, two nutrients have been particularly well studied and show convincing evidence, and that is magnesium and riboflavin. However, all nutrient deficiencies increase risk for migraine progression. So now, environmental factors. Air pollution. So many studies on this recently. It has emerged as a significant modifiable risk factor that contributes to overall migraine disease burden. Again, it's important to clarify that we're not just discussing acute attack triggers here. Rather, these are factors that increase the long-term risk and severity of migraine disease. So you might be wondering, okay, air pollution, what do I do about it? We don't really have control over the level of pollution where we live. So from a clinical management perspective, addressing these environmental risk factors can be part of a more comprehensive approach to reducing this long-term migraine burden. So air purifiers with HEPA filters can be talked about. HVAC systems with certain filters can remove pollutants. And this might not be feasible for most people. However, if living in a high pollution area, relocating is an option. So technically it is modifiable, but this requires aggressive resources. It isn't for everyone, and it is a great burden. But for those that have that option, it is a modifiable risk factor. Stress as well. It's really, really easy to say decrease stress levels. On the other hand, it's very hard to do. However, from a neurobiological perspective, stress activates the hypothalamic pituitary adrenal axis and sympathetic nervous system. It leads to cortisol release, catecholamines. These changes can then trigger the trigeminal-vascular system implicated in migraine pathophysiology. So technically also modifiable. For example, high stress job, you can quit it. Family situation, you can leave it. It really just depends. Easier said than done, of course, but for completeness sake, we have to introduce it as a modifiable risk factor. And what's interesting is that many patients also experience what we call letdown headaches. So let me just write this here, a letdown headache. So this occurs actually after stress has been resolved. So there might not be a migraine attack during the stressful event, but it might occur after the stressful event. After the stress resolves, so if it appears on weekends, for example, or the beginning of vacations, that's because cortisol levels suddenly drop. However, it still is due to stress, because if the stress was not there, there would not be a letdown headache. So finally, we're in the comorbid diseases category. This is the last modifiable risk factor category. This is a crucial aspect of migraine management and involves addressing comorbid diseases that can disrupt physiological homeostasis. Any chronic disease, and I want to emphasize this, any chronic disease can lower the threshold for migraine attacks by creating systemic stress, inflammation, neurochemical imbalances. So any disease disrupting homeostasis can contribute to migraine progression. Incredibly important, treat all diseases. So diabetes actually serves as an excellent example. In fact, migraine patients should consider having a CGM or continuous glucose monitor. Well, for type 2 anyway, because almost everyone with type 1 diabetes does have a CGM these days. And cardiovascular disorders, especially conditions like congestive heart failure, they can impact migraine through vascular mechanisms and altered cerebral blood flow. Now, there's a bidirectional relationship between migraine and cardiovascular disease, particularly in women. And of course, there are other conditions not listed here because we can go on all day. They all fall under untreated chronic diseases. So respiratory conditions like COPD can contribute to migraine through hypoxic mechanisms. Even obstructive sleep apnea, when treated with CPAP, has been shown to decrease migraine progression. And it's great because treating these conditions, other than improving migraine, may also decrease mortality and morbidity. Lastly, it's important to remember that incremental changes across all these modifiable risk factors will likely yield better results than focusing on a single factor. So do a little better at sleep, do a little better at managing stress. All of this adds up. The goal is to raise the migraine threshold. Addressing as many modifiable factors as possible will do this. All right, that's all for today. Thank you for listening.